The time that you answer a precordial thump is when a patient needs defibrillation. A precordial thump. A thump is essentially equal to what? What is a thump equal to? Thump. Bang. What's that for? Besides being fun. What's that for? Rib fractures. No point. Okay? No. Out of bounds. What's a thump for? Heartbeat. No. Stimulate. Yes, it stimulates you. Okay, but so does CNN. Okay. It's a defibrillation. It's like a little shocky poo getting thumped. A thump is a little shock. A thump is a little shock. It's a little defibrillation. It's just a little 10 or 20 joules, depending upon how hard you hit them and how big your hands are. It's a little 10 or 20 joules of shock. Now, normally shocks, you'll notice I didn't make a big deal about the dosing of the shock. It's 200, 300, 360. 200, 300, 360. But I didn't make a big deal about dosing. When have I told you the dosing of anything today? When have I told you the dosing of anything? Never. Is that random? What I do seems random, but it is not random. Can't be random that I did not tell you doses. There must be a reason I have not told you doses. Obviously, not obviously, but what's the reason then? What? Not on the test. If I haven't told you, it must mean you don't need to know it. No boards test dosing. Now, one exception might be just these drugs that we're talking about now, the ACLS drugs. The epinephrine is 1 milligram. However, atropine, in that case, it's 1 milligram. And lidocaine is very different because lidocaine is, oh, come on, 1 milligram? No, 1 milligram per kilogram. Oh. But I didn't make a big deal about dosing of electricity, whether it's 200, 300, 360 joules, because the boards are not as concerned with the dosing of the electricity as they are with you to know who gets shocked and who gets drugs. They're a lot more concerned that you left the guy with VTAC like this. Yo, hey, ho, ho. Oh yes, but his blood pressure is normal. Shock. Any one of those. Shock versus drugs is more the issue. Remember, right? What do you see, Arjuna? I see the eye of the bird. What do you others see? I see my hand. I see the tree. I see the bird. I see the bow. I see the limb of the tree. What do you see? I see the eye of the bird. Hypotension, chest pain, shortness of breath, hemodynamically related confusion. Hypotension, shortness of breath, chest pain, hemodynamically related confusion. Those four things. Okay? 1 milligram a kilogram. Thump, shock, it's a little shock. You might say, oh, what's a little 10 or 20 joules going to do? Well, not very much. Except there's an interesting thing about defibrillation. And the interesting thing about defibrillation is the amount of energy that you need to successfully defibrillate someone is very, very little at the beginning. Right after someone develops VTAC or VFib, you only need a tiny bit of energy to defibrillate someone. Later on, after 5 or after 10 minutes, you could hit them with lightning. It wouldn't make any difference. But at the very beginning, it's a tiny amount of energy. Bang. How would you know for sure that it's at the beginning? How would you know? You see it. You saw it happen. It happened. There it is. He just developed an arrhythmia. I saw it. You saw it. It happened. It just happened. Just happened. I saw it. Witnessed. You saw it. I saw it. I witnessed it. Can I get a witness? Yes. You saw it. Amen. All right? But no matter how satisfying as it may be to thump someone, believe me, I've been looking for an excuse. Bang. How satisfying. No matter how satisfying as it may be to thump someone, it has to be a witnessed arrest, and you have no defibrillator. No machine. You know it's VFib, VTAC, and they need to be shocked, and you have no machine because it's not as good as the defibrillator. That's when you answer a thump. You can resuscitate people past 10 minutes only for people who have hypothermia. That's it. Because CO2 production of each cell and oxygen consumption is directly proportional to body temperature. The lower the body temperature, the less oxygen each cell consumes. The lower the body temperature, the less CO2 each cell produces. Ask Walt Disney. He's still got his head frozen around there somewhere. Low body temperature decreases metabolic rate. Okay? And the only thing I didn't mention there was when I said pulseless, there was VTAC, VFib. The only issue I have is the last arrhythmia is asystole. Asystole. What are you going to answer for asystole? A very important rhythm because we're all riding out of here on this bus. What do you answer for asystole? Okay, guy gets up in the opera, falls to the floor. Annie, are you okay? No, I'm not okay, I'm dead. Help, help, help. Open the airway. Pump, pump. Do chest compressions until you get the EKG. The EKG arrives. Up, asystole. What is the next best step in the management of this patient? What is the most appropriate action at this time? The answer is shock is the thing you've come here to learn. Because shock is the most common wrong answer. Shock is the most common wrong answer. Let me tell you about this most common wrong answer thing. Let me tell you what the point is. Because this is hard to take. Not everybody has as good a sense of humor as you have and as our friend from this morning has. Okay? You look at questions. You go, oh, A, B, C, D, E. Oh, you know what? Nah, it isn't A, it isn't D, and it isn't an E. That's not it. You know, I don't think it's C either. I'm sure it's A or B. Oh, but is it A or is it B? Is it A or is it B? Oh, God. Now, if I tell you that shocking asystole is the most common wrong answer, what is that telling you? It's telling you what the right answer is. That's the point. You think you come here for the right answers. You'll get the right answers. But the other thing is to know that which is definitely wrong in each circumstance is the same thing. Almost the same thing. You come to find out where you are wrong. I told you. It's like group therapy. Okay? You don't shock asystole. What does shocking do for you? Bang. Electricity. What does it do for you besides burning all the hair off your chest? It stops the heart. What would that stopping the heart be called? Asystole. It causes asystole. What? You mean shocking causes asystole? I don't use it to asystole because it causes asystole? Yes, that's right. I don't want to make it asystolic. I can't get it any more asystolic than it already is. It's already in asystole. So I can't shock asystole because it's not like jumper cables for the car. Epi, atropine. Epi, atropine, epinephrine, atropine. Epinephrine, atropine. Don't shock it. Epi, atropine, for asystole. Pacer. Asystole, epi, atropine, they're still dead. You know what they say? They say, consider pacemaker. I'll consider it. What does a pacemaker, a little wire into the heart, or the external pacemaker, what does that actually do for true asystole? Nothing. They say consider. Oh, I'll consider it. Because I have asystole. I have no systole. I'm without systole, otherwise known as dead. This is not very good. I'll consider it. Why? Because I gave epi, and I gave atropine. I gave epinephrine, and I gave atropine. When do I answer intracardiac epi and atropine? Never. Those are always wrong. Oh, I'll consider it. Why not? Epi, atropine. I don't shock. I'll consider a pacemaker. Why not? Because maybe it's really slow bradycardia. And I missed one of the beats. Why not consider it? Because if the epi and the atropine did not work, and I can't shock them, or it won't do anything, why not consider the pacer? Because other than that, what should I be considering? Above ground burial versus cremation. Because there's nothing else to do. There's nothing else. So why not consider it? You got no other options. Not going to hurt you. He's dead anyway. Consider, why not? Okay. You get very, very few EKGs on step 2. Very, very few EKGs on step 2, which are not reproducing very well here in this thing. Very, very, very few EKGs. How many? 2.5. How do I know exactly how many you get? Very, very few. How many? Questions number 12 and 147 will be. I don't write the test. It'll be a conflict of interest. All right. So the point is, in all the questions in all the day, you only get 2 or 3 at most. 2 or 3. Very few EKGs. We used to have an EKG section that went for hours. You know, they had like 2.5 hours, 3 hours of EKGs, then 2 hours, then an hour and a half, then like for what? And half the time, those 2 EKGs you get, you could answer them without even needing to read the EKG. Because you could tell what the diagnosis is from the case. Let's see what this one is. Was ist das? Co to jest? ¿Qué es esto? It's not ST elevation. It looks like ST elevation. I agree with you. But the shape is wrong. The shape is wrong. QRS? No, the QRS is less than 3 small boxes. The QRS is less than 120 milliseconds. So that's not it. Normal. Well, you can't tell V1, V2 because I'm not telling you which one it is, V1 or V2. PR. No, the PR is normal. The PR should be less than 5 small boxes, less than 200 milliseconds. Each small box is 40 milliseconds. Each small is 40. Each small is 40. 5 times 40, 200. 5 small boxes. The PR is normal. It's less than 5 boxes, which is 5 times 40, 200 milliseconds. Okay, the PR is normal. Left ventricular hypertrophy. No, you can't tell LVH off of one lead. Can't tell LVH off of one lead. Bradycardia, that's what it is. It is bradycardia. It is bradycardia. It's bradycardia because it's simply slow. It's largely normal, but it's simply slow. If the next large beat, if the next large complex was on the next big box, this is how you count. Let's look over here. If the next one was here, the rate would be 300, 150, 100. Quiet, you. Shh. 300, 150, 100, 75, 60, 50. If it's on the next big one, it doesn't reproduce out here as much as I'd want it to. The next beat was on this next big line. Rate is 300, 150, 100, 75, 60, 50. It's simply bradycardia. It's simply slow. It's simply slow. Let's go look at the one on the bottom. Maybe that'll reproduce better. 300, 150, 100, 75, 60. It's under 60. It's simply bradycardia. It's simply slow. If this man has lightheadedness and confusion, what will you do for him? Lightheadedness and confusion, what will you do? No, you only shock if it's rapid and unstable. Rapid and unstable. Rapid and unstable. Hypotension, chest pain, shortness of breath. Atropine if it's unstable. Atropine if it's unstable. You give him some atropine, he's still unstable. What do you do next? Pacemaker. Transcutaneous first or transvenous? Transcutaneous first, then transvenous. Unstable, atropine first. If it stays unstable, pacemaker. What is it? What is it? What is it? It's not normal. Yes, it's wide. Yes, it's more than 3 small boxes. Yes, it's wide. That's not good. No bueno. You want to keep on the EKG, and my voice is good enough on it. Let them see the EKG. That's good. Good. You're right on. Okay. Digoxin toxicity. What's the most common what arrhythmia can you get with digoxin toxicity? What arrhythmia can you get with dig toxicity? What arrhythmia can you get with digoxin toxicity? Bigeminy. Yeah, jumping bigeminy. You can get jumping bigeminy. That's true. What else can you get with digoxin toxicity? What? Everything. Do you know that for sure, or are you getting to read Conrad Fisher? You can get anything with digoxin. What's the most common? Dig toxicity can give you anything, but what's the most common? No. SVT with block. SVT with block. Digoxin toxicity. It's not necessarily digoxin toxicity, and it's certainly not the most common arrhythmia for dig toxicity. Digoxin toxicity is SVT with variable block. What's this in the... It's not bigeminy. I know you want it to be bigeminy. Bigeminy is where every other beat is a PVC. Bigeminy is every other beat being a PVC. This is a couplets. Couplets are 2 PVCs. Couplets are 2 premature contractions. They're simply premature ventricular beats. They're simply premature ventricular beats. A couple of PVCs. Common stuff. Bradycardia, PVCs, common stuff. Okay, for step 2. Nothing exotic. Step 2 doesn't expect you to read EKGs much. There's very little image identification. Very little. If you see one of these, it's a PVC. If you see 2 of them, it's a couplet. If you see 3 of them, it's a triplet. If you see 4, it's... No, not quadruplets. SVT, not SVT. What's the S stand for in the SVT? Supra. And what's supra mean? Above. Above. Above the ventricle. And above the ventricle are the atria. When I was in medical school, the atria were above the ventricles. So they're still above the ventricles, I think. So the point is, this is not supraventricular anything. How do I know that this is not supra, above the ventricle? On me? Jim, on me? How do I know it's not supraventricular? I hear a lot of mumbling. No, because the complexes are wide. This is your heart. This is the SA node, AV node. Impulses come down here. Impulses come down. Trying to get through that AV node. And once they get through the AV node, they go through the bundle of His, the Purkinje system, and spread out to the rest of the heart. In supraventricular arrhythmias, in people who have AFib, A-flutter, and SVT, once the impulse gets past the AV node, it goes down the normal cardiac conduction system. And if it goes down the normal cardiac conduction system, is it rapid or is it slow? Atrial arrhythmias. Atrial arrhythmias is SVT, Atrial fibrillation, atrial flutter. And once they get past the AV node, they go down the normal conduction system, and that makes them rapid. And if they're rapid, that makes it wide or narrow on the QRS. Narrow on the QRS. Wide things on the QRS. Wide means you're originating from some ectopic focus out in the myocardium. You're originating from some ectopic focus out in the myocardium, so therefore you are spreading from myocyte to myocyte to myocyte, and it's like you want to go between here and Sacramento, and you don't do it on any highway. You go through every side street. You'll get there. It'll just take you a heck of a lot longer. And that means it's wide, indicating slow conduction through the myocardium. Anything that is slow means wide. Slow means wide. These are ectopic beats. They're originating in some ectopic focus. 1 is a PVC. 2 is couplet. 3 is triplets. And 4 is not supraventricular. Supra means narrow. Okay? And that would not be narrow. 4 of them would be ventricular tachycardia. Ventricular tachycardia. V-tacking. Merle, lights, thank you. V-tack. These are couplets. Bigeminy is every other beat being a PVC. What is this? A pacemaker. Well, you know, it looks a lot like a pacemaker, but it's not. Huh? Would this make you feel better? How about like this? I gotta tell you, no matter which way you slice it. Ectopic atrial. You know how you know it can't be atrial? Because when it's atrial, it goes past the AV node. And once it goes past the AV node, it goes down the normal conduction system. And if it goes down the normal conduction system, is it wide or is it narrow? Narrow because it's fast. Atrial arrhythmias are narrow. Ventricular things down here are slower. And slower means wide. Is this narrow or is this wide? That's wide? No, it's wide. Wide, wide, wide. What is this? HIV? No. HIV. I guess your only tool is a hammer. You tend to see every problem as a nail. Okay, what is that? This is Bigeminy? Why, yes it is. Jumping Bigeminy. Yes it is. Yes, it's what he said before. It's what we were talking about. It's Bigeminy. Every other beat is a premature ventricular contraction. Every other one. You have a PVC and a normal beat, and a PVC and a normal beat. And this is to show you the difference between a normal beat, narrow, PQRST, and a wide one. This is Bigeminy. If every other beat is a PVC, it's Bigeminy. What is that? Hello? Pinocchio! What is that? Huh? The leads came off his chest. Good, Oscar. Good. That's good. Oh, take a chance. I promise I'll never hurt you. It's asystole. That's right. It's asystole. It's asystole. You see, asystole means there's no rhythm here. There's no rhythm here. This person is dead. I know what you're expecting. I know. You've been watching those movies, Flatliners, too much. You've been waiting. Stay in the rhythm. Stay in the rhythm. Okay? You've been you expect people to be like asystole, like this. But I'm sorry, but there's biological variability. Unless you're putting the rhythms, the EKG leads on a grapefruit, you're going to have some amount of biological variability. A little bit. This is asystole. There's no contraction. There's no rhythm going on here. It's just asystole. What's the next best step in the management of this patient? Epinephrine. The epinephrine doesn't work. He's still dead. What do you do now? Atropine. That's correct. He's still dead. What do you do now? Epi some more, and he's still dead. Atropine, he's still dead. Atropine. What do you do now? You consider a pacemaker. Why not consider it? Why not? Why not? Because right now, he's just mostly dead. And if you give etiatropine, it doesn't work. Then he'll be all the way dead. How long do you have to resuscitate him? 10 minutes. 10% a minute stay permanently dead. It's asystole. It's asystole. When do you thump asystole? Never thump asystole. Because asystole is like a shock. I know you know. I know you know, Nick. It's on one gyrus. It's not passing the corpus.
Never knows.
Who's your daddy? There you go. Next one. It's V-tacking. She's V-tacking. V-tacking. Now do you see wide complex? If you saw just one of them, what is that? PVC. Ready? What's that? A couplet. 3 of them? Triplets. 4 of them? V-tac, not quadruplets. You guys spent too much time with Dr. Sakala. Okay, it's V-tac. It's V-tac. Okay, this is him right here. It's Reza, right here. How do you feel, Reza?
Great.
Reza feels great. Okay, what would you do next for him? Leave him alone. Let him die. Let him die. He's suffered enough. Get a consult from the Hemlock Society. Well, Dr. Kevorkian over there wants to do nothing for you. No, Reza feels great. He's got V-tac. What do you want to do for him? You don't just leave people alone with V-tac. You got to do something for them. Lidocaine. Reza, are you stable?
Yes.
Yes. Alhamdulillah, huh? Okay, yes, he's stable. Lidocaine. What if he falls to the floor dead? Shock. Stable, lidocaine. Unstable, shock. 1 or 2 more. We're almost done. You get shown, I show you a couple of them so that you'll pick up some very common things. You won't even need them half the time. You can figure it out just from the case. It's what? Torsade? Is it Torsade? Torsade is the most common wrong answer for this EKG. Ow. Ooh, that hurts, Daddy. Ooh. I know it looks a little like Torsade. It looks a little like Torsade because over here you're having it looks like going. I know that. I know it looks like Torsade. I know it does, but it's not Torsade. Here, this doesn't look so Torsade-y, does it? No, because you know what it is? The ventricle's having a seizure. That's it. Universal ventricular fibrillation sign. Okay? Not only is this person not breathing, but his phone calls have tended to taper off lately. What's the next best step in management? What? What do you do next here? Come on. Shock him or intubate him? Shock. Shock, shock, shock. He's still dead. Now what? Intubate epinephrine. Then shock again. How long do you wait in between those shocks? No amount of time. How long do you have to save him? 10 minutes, that's right. You go as fast as you can. And there's no minimum and there's no maximum. 93-year-old guy, metastatic prostate cancer, walk in the room, VFib, thank you very much, it's done. Walk in the room, Princess Diana. Princess Diana got coded for 2 hours and 45 minutes. Princess Diana, it's princess. Okay? But there's no minimum, no maximum. It's not like we code you for 20 minutes if you have private insurance, 10 minutes for HMOs, 5 minutes for Medicaid. Okay? All right? So, 10 minutes to survival, but no minimum, no maximum. VFib, VFib. No organized rhythm, no organized rhythm. It is VFib. It is VFib. Last EKG. Well, let's do the rate. 300, 150, 100, 75, it's normal. Normal rate anyway, normal rate. P, QRST, P, QRST, P, QRST. What is here? Hyperkalemia. Why do you say hyperkalemia? What? Peaked. Peaked. Is it peaked because it's pointy or because they're large? And you're talking about peak T waves. What matters? No, it's not the size that matters. It's the shape. Pointy, pointy, pointy. Not peak T waves. Was ist das? It's the most important EKG for you. It is normal, 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 normal. Normal, normal, normal. P, QRST, P, QRST. No ST elevation or depression. No Q waves. Normal. It is normal. It is a normal EKG. You do not need many EKGs. Very tiny amount. Never heard of more than 4. I've been asking for 10 years, never heard of more than 4 on any exam. Usually 2, one of which you don't even need to read the EKG. You can get it from the case history. Okay. Okay. When you study, keep in mind that there is the exam, but if your only highest point is the exam for studying, it will feel painful. If you are conscious of the goodness that comes from the knowledge after that, and what it can do to be of service, then the exam will feel smaller and your process will be filled with more joy. Okay, Bapu? Huh? Stay happy, and I'll see you in hematology.